next session, even though it says part 2, we're probably on about part 25 by now, but I'm going to talk about the principles of human performance. Why on earth am I talking about this? Because what you'll see as I go through, there's some really brilliant work by somebody called Ted Conklin, who actually kind of nails it for me in terms of the way that we need to start thinking about safety in a more broader way. So he believes that the 5 principles of human performance are the following. Context drives behavior and decisions. Error is normal. Blame fixes nothing. Learning and improving are vital, and how people respond and act to failure matters. And that's what I'm going to now talk through with you, as well as I'm going to talk about safety 1 and safety 2 in this session as well. So context drives behavior and decisions. What does he mean by that? And what's my interpretation of that? Well, basically it means that safety isn't in isolation. Safety is just one component of your system and requires us to think about systems when we think about how can we improve safety. So this is the world of systems thinking. And I know that seems quite laboured in my point, but I think that some people really don't really understand what systems thinking is as such. And what it is that systems thinking is a way of helping people to see the overall structures, patterns and cycles in a complex system. So you don't see your incident in isolation. You don't have an incident report or an incident investigation or even an inquiry that just looks at a small component of how the whole system is working, how those people are interacting with each other, the tools that we use, the resources that we get allocated, the procurement systems, the support systems, the financial systems, and so on. All of these systems are working together to try to make it as seamless and as an effective performance as possible. But in safety, all too often, we only see specific events. We think about one incident or one investigation and we hone down rather than actually broadening out. Because what we need to do is broaden right out, because we need to identify the solutions that address the different problem areas throughout the system. So when we talk about addressing an issue on, Unit 1, Ward 5 or whatever, we're not actually going to change that much if we don't think about, does this affect other systems, other units? What is the broader conversation we need to have and to be able to share in that psychological sharing safety bit, where we need to share beyond the beyond our team, the beyond our unit, maybe even the beyond our organization. It is useful, however, to distinguish between the different types of what we have in our systems. So very, very briefly, there's some brilliant work by some people called René Amobete and Charles Vincent. They work collaboratively on an awful lot of things, and they've written a book called Safer Healthcare, which is free to download. All you have to do is go to Google. I think it's Springer is the public publishers, but Safer Healthcare, Charles Vincent, René Amobete, you can download this for free, this book. And they talk very much about how healthcare is divided up into these 3 systems. They're either ultra safe, or they're high reliability, or they're ultra adaptive. And we need to understand which bit are we working in, and you will be working probably in all 3 bits of that. You're probably working in ultra safe systems where such as things like chemotherapy or radiotherapy, where we actually need to exclude risk as far as possible. Now, you would have thought that would be every aspect of healthcare, but sometimes risk is inherent in the system, as it says here in terms of the ultra adaptive system. So ultra safe systems are those where you want every nano bit, every micro decision, every choice made to be as safe as it possibly can be, knowing that sometimes it might not be, because you can never have 0 harm. So that's an ultra safe system. Chemotherapy, radiotherapy being that example. High reliability systems is where you want the same replication, the reliable systems to be carried out time and time again. You want that for ultra safe systems, but you might not be able to get that, the ultra safeness, in the vast majority of what you're trying to achieve, because you cannot prescribe every single eventuality. And this is where risk is not sought out, but it's inherent in the job. So in ultra-safe systems, we worry about the process and we get the people to try to adhere to the process. In high reliability systems, the people and the processes are as important as each other. An example would be surgery, where they're both predictable processes and also have clear inherent risk. The predictability is that you should be able to do a tonsillectomy time and time again in a reliable way, in the same way, with the same success. And the risk can be mitigated by skill, adaptability and control. And then aspects of our healthcare are ultra-adaptive systems. And I imagine this is possibly where you feel like you work mostly. Risk is inherent in the system, and much of the skill is in the people. The people are more important than the processes because they manage the risk moment to moment. An example will be the emergency department, where staff have little control over what comes in and the situation changes from moment to moment. So this is the work Chris Turner and I have been doing together. And then what we need to understand is that there are also components of our healthcare systems which are both simple, or not both, they are either simple, complicated or complex. And very briefly, a simple system is when you have a recipe or a protocol, like the ultra-safe areas. An example in life would be making a cake. Once you've mastered it, you can follow that recipe and you can carry it out with relatively high assurance of success, unless you're me, I'm rubbish at making cakes, but anyway. So a recipe, protocol, procedural document, simple. And a simple system works best for ultra-safe. Because actually, unfortunately, you can't, as I've said, prescribe for everything. When you go to a complicated system, it's weirdly similar to a simple system, but increased in scale and requirement. And this is sort of where it blows my mind a little bit. So building a rocket to go to the moon is considered complicated, not complex, because it's a bit like making the cake. Once you've made a rocket, you follow the recipe, you can develop another one and another one and another one, and you want a relatively high degree of certainty of outcome if you repeat it. I know that doesn't always work, but that's the kind of definition that most people are using in terms of complicated. And then you get complex systems, which is healthcare in total. And we have complex adaptive systems in healthcare that have components that are complicated and components that are simple. And a complex adaptive system or a complex system is based on relationships, interdependencies, and interconnections. So as you can see, it's the people, the resources that we have, the tools that we use, all are interconnected and interdependent upon each other. And the relationships are crucial. So that comes back to that ultra-safe, ultra-adaptive area in healthcare, where we are dependent on our relationships with each other and our ability to adapt. They cannot be understood solely by simple or complicated approaches to either evidence, policy, planning, or management. So you can't manage a complex system in the same way that you might manage a simple system. A day-to-day example is raising a child. You can raise one child and it provides you with some experience, but it gives you no assurance of success with the next one, or that you'll get replication of the next one. You don't raise one child and then another is exactly the same and another is exactly the same. So it's not complicated or simple. And healthcare is not like that either. It is complex. But safety science seems to have simplified itself. It seems to have gone into that whole simple mode. All you need is a recipe, a protocol, and everyone will be safe. We like to find those neat answers, and we find the bits that make sense to us, and we find what we think is a cause or causes that are easy to find. And that once we think we've found this easy cause, we presume there's some kind of cause and effect, a cause and impact, a cause and outcome, when in fact there may be no link between the cause and the impact or outcome you might see. There may be multiple variables in the middle of that, but you've lumped on some aspect of cause and made a quite dramatic decision to say that this has caused this effect or impact. It is not like that in safety. And that the danger is that investigators latch onto superficial causes to the exclusion of much more fundamental causes, and they make recommendations on those superficial causes rather than the fundamental ones. But healthcare is changing all the time. Not only is it a complex adaptive system, it's changing all of the time. It's a bit like being a landscape painter. You're standing in front of a landscape and every minute it changes. The light changes, the mood changes, the trees move, people walk in front of you, the weather changes. Everything is changing all of the time. And you can only capture that fleeting moment, usually probably just by a quick photo, but it will only give you that fleeting moment. It won't tell you what's happening, what happened 5 minutes before, and it won't tell you what's happening 5 minutes in the future. This is what we do in safety. We think we can capture that fleeting moment and believe it shows you how everything was and how everything is going to be. It isn't. Safety is not a photograph. It is, and healthcare is not a photograph. It's constantly moving. And as a result, it affects things like our memory and our recall. And we do very, very strange things as human beings, but that's for another day. So a healthcare as a complex adaptive system is this. It's a dynamic network of interactions. Dynamic, constantly moving, changing. It's a network, so everything's linked like a spider's web. And the people and processes acting in parallel are constantly reacting to those other people and processes, which in turn influences the behavior, decisions, and choices of the whole system. So like chaos theory, the butterfly theory, and so on, one move from one person will get somebody else to make a decision, which makes somebody else make a decision, and so on. So constantly changing and moving as things progress. But people think that they can actually start to do weird things like imagine what it is and prescribe for it. And actually the whole world of human factors tries to study this in using terminology like work is imagined, work is prescribed, work is disclosed, work is done. Work is imagined is those protocols and the policies and that people write, the standards that are set, the decisions made by the Department of Health and so on, is where they imagine this is what people's real life is like, and then they dictate this is what you should be doing. And that turns into work as prescribed. So I'm now going to prescribe an area of work, and I would expect you to adhere to this. And if they start to prescribe it in a lot of detail, so that you get 10 pages worth of a policy or a procedure, when actually you can't do that, because work as done is very different. Work as done is, as I've said, it's movable, it's changing, it's doing things all the time. And the only people who know what work is done is really like, it's not the fantasy people, the people with the imaginations, is the people doing it. But you will only find that out if people feel psychologically safe to disclose what they're actually doing. Because the work as imagined has been prescribed. Let's say it's something that tells you have to do 5 steps, but the people who actually do the work only do 3. Everyone knows they do 3. They never do that 4th and 5th for all sorts of very, very genuine reasons. But they won't tell you they don't do the 4th and 5th. If you don't have a psychologically safe environment, they will tell you they do all 5. They will keep that hidden. It is something that is a norm and a habit that everyone else knows about, but not the people you want to disclose to. This is the subtle problem with inquiry, investigation, and regulation, because the inquiry investigators and the regulators ask people who know that you only do the 3 steps, do you do the work as it is prescribed? And if they don't feel safe, they will say yes. So you never actually truly understand what actually gets done. But this is what people do astonishingly every single day. They adapt and they adjust to the demand and the change of the performance accordingly. They adapt and they adjust all of the time. They deal with any unintended consequences that they get from all sorts of ways, such as interventions that are designed by those that imagine what their work is like. They have to interpret the policies and procedures and apply them to match those conditions and the patients in front of them. And crucially, they detect and correct when something's about to go wrong. Do you know how your work is actually done? And if you are a leader of a unit or a team or an organization, do you know how the work is actually done? Do you understand the normal everyday functionality of your organization? And this is what Eric Holnagel would say is crucially the actual aspect of safety that he thinks that people should be worrying about. Everyday functionality of your organization. Do you look for patterns in the behavior of your system? Do you understand the warning signs? Do you understand the times that it's actually working well? Do you look for interconnections within the system rather than the isolated problems? Or do you just look at isolated incidents on their own? So if we've gone from the context, and that's what we were describing just previously, let's look at the second principle that Todd Conklin talks about. Error is normal. Even the best people make mistakes. So error are not choices. Why people think they're choices, I have no idea. You can't remove error. And so this desire for zero harm is impossible. But you can start to think about how do we actually try to design out error. So you can put in processes and systems that make it very hard for people to make mistakes. And you build in some level of error tolerance. And you help defend against the inevitability of error. Every single person makes errors, mistakes, and so on, cock-ups or whatever you might want to call them. We do them every day in our daily lives. We will do them at work. We are not heroes or superhuman. We are not people who go in and suddenly change into some different uniform that makes us error-free. It's a complete and utter fallacy. But the problem is we expect perfection and we are very rarely tolerant of error. But the more complex the system is, and as I've just told you, in context, healthcare is a complex adaptive system. The more complex the work is to perform, the higher likelihood for error. And complexity always creates error opportunities. The more complex it gets, the more chances for error, and can lead to people adapting and adjusting a rule in order to maintain safety. So we place frontline staff in more and more complex environments and are shocked when they make more and more mistakes. So what can we do? We can understand various things. So there's a weird saying that people have, which is we don't punish people for honest mistakes. And as I've said there, it always makes me feel a bit odd. If there are honest mistakes, does this mean there are dishonest mistakes? Really, a dishonest mistake, surely that's an intentional aspect of behavior. In safety, the word dishonest is often replaced with the word violation. I don't know if you've heard that term. Violation is usually when the worker, the employee, the staff member purposefully chose to break a rule. Well, that's how it's perceived anyway. However, Ken Catchpole and others have done some amazing amounts of work looking at the world of safety violations in healthcare, and believe very strongly that policy and protocol violations reflect the efforts of well-intentioned professionals to carry out their work efficiently and in the face of poorly designed systems. So we come back to our systems thinking. If we have a poorly designed system that doesn't take into account the complex adaptive nature of our system, and we have policies and protocols that are prescribed and designed by those that imagine what you do, then every single one of us starts to try to work around them. So the kindest thing you can possibly do is review all of your policies and procedures and ask yourself if they're workable and if they're clear, simple, and short. And if they're none of those things, then you really need to change them. Non-compliance with policies and protocols signals a systems problem rather than a people problem. There are very good reasons why people may violate or, as in not adhere to, a prescribed policy or procedure. They don't know it exists. They don't know that it's even there. And even if they did, they don't have the time to read it, or it's unworkable. It's written in such a way by the imagination and it just doesn't fit. And there was a definite need to work around them in order to keep someone safe. Sometimes the policy or procedure might be actually right. It might even be simple and clear and workable, but there are occasionally circumstances when you had to work around them in order to keep someone safe. There are so many examples in life of that, and we've all seen them in things like disasters, like for example the 7/7 bombings. All sorts of people worked around what would be considered safe protocols and procedures to actually keep people safe. We had an awful lot of, for example, staff members from Great Ormond Street who normally deal with children going out and looking after adults and changing everything that they did in order to work around the current policies they had in order to keep human beings safe, the adults safe in front of them. So you can help your staff by reviewing and simplifying all of your policies and crucially have a caveat within them. Somewhere at the bottom of the page, don't care where it is, it says this policy or procedure, or whatever you might be calling it, may be adapted depending on the circumstances that they face. The third point that Todd describes is blame fixes nothing. And we've talked about this for years in healthcare and in safety. And we know that it leads to fear and silence. Human beings are amazing. And please, can we just remind ourselves of this? They are so brilliant in terms of their adaptive creativity and constantly solving problems and adjusting what they do. We rely on our staff to keep people safe. People are the solution, not the problem. They can be all the things we talked about before: inconsistent, unreliable. They get stressed, they get tired, and they can be rude, and they can get distracted and forget things, and they get bored. This is what human beings do, and that's why we have a lack of safety in certain circumstances, because no one is perfect. And this actually holds so true for no matter how much experience you have. Even if you have 40 years experience in a certain aspect of healthcare, even if you have practiced time and time and time again, even if you try to pay as much attention as you possibly can, there will be always the potential for that person to make a mistake. But we don't seem to take this into account when we do incidents, incident reporting, incident reviews, incident investigations. We scrutinize people. We get our microscope and we look at everyone's actions. And no matter how brilliant that person is, how effective they are usually, how much experience they have, you'll find flaws. If you get your microscope out, you will find flaws, especially in the less sensible light of hindsight. I am now looking with my microscope at the sort of things that I wouldn't have done if I'd been in that circumstance. Yet we judge people by one error or one incident, sometimes for the rest of their careers. As Sidney Dekker says so beautifully, in our drive to pinpoint the source of suffering, we succumb to the hunt for a scapegoat. Why do we do this in healthcare? We do this all of the time. I know it happens in other high-risk industries, but we're very good at it in healthcare, finding the scapegoat, the person to blame. And quite rightly, it says here, possibly inflicting even greater suffering on others around us. People really suffer when you blame them. And blame implies an error is a choice, which it isn't. It's clearly the opposite of encouragement. It silences people, so it's a key component of a lack of psychological safety. It's easier to fix in the processes, just to go around blaming people, and it shifts the accountability from the system to the individual. If I blame these people, these errorless people, human beings, I don't have to worry about trying to fix my system, because that's far too difficult, costly, and I don't know where to go. So the crucial thing is that we have to actually pause. At some point, bad things are going to happen to people. They just are. They really are. And what you need to do, every single one of you, is have someone to hold on to. Always have someone who you know that you can call, no matter what, perhaps no matter what time of day or night, who's going to be there and listen to you and to hear from you, your side of the story, but also just to not judge you and to hold you, even if that's metaphorically in this times of pandemic. And what we need to do is help people overcome these three things: personalization, pervasiveness, and permanence. The feeling that it's absolutely all down to their fault, the feeling that it's going to ruin every bit of their lives, and that they're going to feel this bad forever. Because they won't. They won't feel like that in the moment, but over time they'll realize it isn't all their fault, and it isn't going to ruin every bit of their lives, and it isn't going to feel like this bad forever. So we have to allow people to fail, but fail in a really safe way, if that makes any sense. Allow people to doubt and allow them to feel vulnerable and allow them to change their minds. Again, this is part of a psychologically safe environment. Allowing yourself to know that you are imperfect and that you can resist perhaps that dynamism that you're supposed to expect about yourself, and allow yourself not to shoot through life like an arrow speeding with purpose. Allow others to do the same. So that brings me on to number 4, learning and improving are vital, and learning needs to be deliberate. Learning about safety is as equally as important as trying to tackle safety. And we know from a lot of research that's been undertaken over the last 15 to 20 years that we are still not safe. And we're not quite sure why all that concerted effort that we've put into hasn't quite got us to where we've got to. This is the brilliant book by Bob Weers and Kathleen Sutcliffe, Bob Weir has sadly died since writing this book, but his work was absolutely astonishing and is still important today. And he's left a legacy for us in our story of patient safety. It is based around the American healthcare system, but it alludes to the NHS in numerous aspects. And if you've ever worked in safety, you'll know what that definitely feels like. But these are the sort of things that people have been studying over the last 15 years that we need to start trying to do something about. There's a problem with incident reporting. They're completed before anyone actually knows what's happened. They should only be used as notification systems, but they're not. They're filled with hindsight, outcome, and confirmative bias, as are our incident investigations. And they are sadly often used as a threat. The problem with root cause analysis, it's a practice adopted from other high-risk industries, and we've just cut and pasted rather than actually adapted it to healthcare. It is a method of structured risk identification and management, and it isn't a single technique, but people seem to think it is. It's about, for people, they think that it's just about finding that one root cause, but it's a range of approaches, and comes from human factors and safety science. And it can be used to establish how and why an incident occurred, but only if you use it in order to identify how other similar problems might be prevented from happening again. It has its potential value, but as I say, it hasn't been sufficiently adapted for healthcare, used by people who have limited amount of training or carried out by very busy clinicians who are, because of time, pressure, their capacity, are forced to write in short points. And they find bits that make sense to them. Of course they do. And when something's gone, we actually need to capture what's happened as soon as possible. But root cause analysis and the way we do investigations in the NHS is that they take weeks and weeks and weeks. So we don't capture what's happened as soon as possible. We need to change our methods and methodologies to actually figure out, how do we do that? How do we get all of that information right the moment the thing has happened? Because people move on to different shift patterns. I've talked about how the fact that we don't have teams that spend shifts after shift after shift together. And in very large units, some of the same people, you might not work together or even see them for weeks on end. Equally, because we are human beings, our memory and recall become very weak. And as I've said, healthcare is not a photo. It's constantly changing. So we have to grab all of this information while we can. And then we have to figure out, once we've grabbed all of that information, what kind of recommendations are we going to make? And sometimes it might be bold and brave not to make any recommendations at all, because it may be that those recommendations have been made before. All we're actually doing is trying to ask ourselves, what is working about those recommendations and what is not working about those previous recommendations? And should we just revisit them and ask ourselves if we should actually do them differently? There's very little investigations that have been looked at, recommendations stemming from RCA investigations. And it points, though, to any research that has been undertaken that those recommendations are usually very weak. So like reminders or a bit of training, or just tell people to not make mistakes or communicate better, rather than identifying what Jim Reason might describe as the latent causes, like the poorly designed technology, poorly designed equipment, systems, and so on. And if you make recommendations based on superficial things and you make them based on weak solutions, actually those corrective actions may do more harm than good, and may result in very little change. And all you've done is just an awful lot of compliance activity associated with investigating. Equally, if we jump to corrective actions based on a single case, we may actually shift that complex adaptive system in a way that doesn't actually work. So when you've got complex things going on all the time and you just change one part of it, you have to think about those interdependencies and the interreactions that may happen because you change something based on one case rather than looking at the overall factors. You might overestimate the importance of small individual factors versus those important contributory factors that all link up together. So you might never adjust the causal factors, and you might even introduce new risks. But all actually we end up by finding in investigations is a very personalised approach. Coming back to that personalisation, we reiterate that constantly by getting people to write up statements about what they did. And they are asked to look introspectively about their own personal performance. And they will say things like these: I was talking to someone while drawing it up, I messed up, and I will be more careful in the future. I will be more careful in the future is most definitely not a recommendation for change. But this is starting to be recognised. And at a national level, NHS Improvement, the patient safety team within it are starting to develop, as some of you, if not all of you, are aware, a new approach to serious incidents. This is the Patient Safety Incident Response Framework. And in fact, what they're going to try to do is remove even the terminology of serious incidents, because that's associated with blame and punishment and fear. And as it says here, they've been bold enough to say that there is little evidence to suggest that the work that we've done in looking at serious incidents in the past, using things like root cause analysis, have actually led to widespread sustainable improvement in patient safety or benefited patients, families, carers and staff. So there is a recognition that the work that we've been doing in root cause analysis investigation has not done what we intended. So what people are wanting to do is move the conversation on and start to evolve these tools and techniques so that we can start to perhaps learn better and learn more. So what can we all do differently? Before suggesting a solution, it would be far better to use direct observation and care. Understand that work has done that I've alluded to, what actually happens on a day-to-day basis and not what you imagine happens. Identify and address the pre-existing behaviour shaping factors, such as task complexity, the problematic workflow and flawed equipment design that enable error to occur. So these are the things that you should be doing, not looking at why did that person do this, but look at the underlying behaviour shaping factors. When staff identify possible equipment design issues, simulation may be a solution, or ethnography in terms of looking and watching the user use the equipment time and time and time again. It will provide you with deeper insights into the equipment deficiencies. Look at the way in which you make recommendations. Person-based corrective actions will not make a massive difference. They have their place, but they will not make a massive difference. So training, changing your policies and procedures, the use of warning signs, they'll just get you just one step onto the journey of making a difference. But system level changes are what you are actually wanting to try to achieve. But we use the frequency of education and policies as corrective actions, and this reflects their greater ease, as it says here, compared with doing things like automation and forcing functions. Systems level solutions can be costly and labour intensive, but they are worth their efforts. They're worth pursuing. They also require lots of vigilant monitoring to check that the implementation hasn't caused any more hazards or risks. But they are far more likely to succeed rather than simply education and policies. So this brings me on to the world of Safety 1 and Safety 2. Safety 1 and Safety 2 are the yin and the yang of each other. They both need each other. If we talk about polarities that we've mentioned, these definitely is an and. It's Safety 1 and Safety 2. And Eric has been saying this, Eric Holnagel has been saying this quite some time, but a lot of people have got this strange myth or misunderstanding that it's Safety 1 or Safety 2, that Safety 2 replaces Safety 1. It doesn't. By the way, there is no Safety 3, even though some people might think there is. Safety 1 is where we learn from failure. We learn from the incidents, the investigations, and we learn at the moment using methodologies and tools lifted from high-risk industries, which at the moment are only fit for linear systems. We need to change that. And we, in Safety 1, tend to improve things based on sometimes just the one failure. What's wrong with focusing on failure? Well, the thing is that, as I've said, healthcare is not a photo. Things that go wrong are not one aspect of healthcare. They're not this one moment in time. Things that go wrong will be part of a whole complex system of events. And when it goes wrong, it is unlikely to be unique, but is more likely it's gone right many, many times before. So giving medications, you get it right the vast majority of times, and then occasionally you get it wrong. And in the future, you'll get it right the vast majority of times in the future. So when something's gone wrong, we look back and we immediately start finding the bits that make sense to us, as I mentioned before. And we try to prevent the problems of the past, but they won't necessarily solve any of the problems in the future because we've got this changing system. Focusing on rare failures doesn't explain why human performance practically always goes right. Safety science doesn't seem to take that into account at the moment. It uses that simplistic cause and effect that I've mentioned. Because we like to find those neat answers, because we latch onto those superficial causes, because we seek explanations that are based on linear causality. Linear causality simply means that you can do something, you can track back in a neat line, a bit like a production system. So you can track all the way from the start of developing of a car, for example. You have all these parts that are all disparate and all over the place, and we add in one part, and before you know it, at the end we've got a car. A bit like that whole cake recipe, simplified and complicated stuff. We have a recipe, we have a procedure, we'll create a rocket, we'll create a car. Healthcare is that complex, so it can't be a linear causality system. So Eric Hornego asked a very, very simple question. Why do we always focus on everything that goes wrong? And what we know in healthcare through retrospective case note reviews is that around about 10% of the care that we provide leads to harm. It's a relatively flawed statistic, but let's go with that. And again, that's another lecture in itself. It's flawed because it's based on medical records and subjective views about what is harm. And it's only based on acute care, and it's only based in a very small number of acute care sites. But what we have is this statistic that's been used time and time again. 10% of the care that we provide causes harm. So therefore, you have to ask yourself, what's the opposite statistic? There is always an opposite statistic from any statistic, and that opposite number is 90%. So 90% of the things that are provided, care, delivery, operational systems, and so on, go okay. They may not always work, but they ultimately go okay and don't result in any harm to patients. Based on those statistics, the opportunity to learn, if we just looked at the 10%, is very little. So we need to understand, how can we learn from the daily life of an organisation the 90% when nearly everything goes well? So what's the alternative? We can't anticipate and prevent every harm, given that overwhelming complexity I've talked about, the unpredictability of healthcare, but we can dramatically reduce the number of harm by things like following best practice, by helping human beings execute that best practice, by setting aspirational goals. Another acronym which I've explained is as low as reasonable achievable, or as low as reasonably practical. That's reducing the risk to as low as possible. We can rethink the way we do safety by using things like safety 2 methodologies and resilient healthcare. And we can motivate differently. Imposing goals of zero harm promotes compliance and gaming, a lack of ownership, and I would say fear. When we talk about things like never events and serious incidents, most people are really, really fearful of all of those things. So what is safety 2? It's about learning from success rather than learning from failure. It is about using methodologies and tools that are fit for complex systems. So we take that safety 1 and we enhance it. And we ask, why has it failed this time when most of the time it goes okay? And we absolutely know that the workers are not the problem, they are the solution. So we need to help the workers continue to be the solution. As the lovely Liz and Molly say, we think of failure and a success as opposite. They're the polarities. But if we did a polarity map on failure and success, we would find that in fact that they have connections with each other and that they are both part of the same thing. So how do we go about doing this? Well, it's really hard. I don't make any bones about that, because it's easy to see the failure. And we're nudged and required to do so. And we're nudged to understand why the unexpected happens by regulators, by the inspectory systems that we have, the people that scrutinize us. And it's really difficult to see when nothing happens, the invisible. We've saved some lives today, but we haven't noted that. We haven't harmed anybody today, so we got through the day, so why would we even notice that? So what happens on a day-to-day basis, and why would we want to understand it? That's because on the everyday, our everyday lives, performance adjustments and variability create safety, and so therefore they're at the core of safety too. They're a positive thing, but as I say before, they've been interpreted negatively as deviations, violations, and non-compliance. So we need to treasure that adaptability, understand it, treasure it, don't constrain it, and rather than look at the ways in which we can fail or malfunction, we should understand that everyday performance. So what is happening when nothing bad is happening? We look at that broad area in the middle of that distribution curve, not the either end, not the tails of the normal curve. What happens frequently? What are the daily activities? And it's all safety. So safety 1 and safety 2 is simply a refreshed view. This is safety. Safety is using the failure or the areas of high risk to study why they normally go okay. So you can still use those things like incidents and never events, but you ask yourself, this happened, but I'm assuming that it's happened right time and time again. It's been successful time and time again before, and will do in the future. So why did it fail in this instance? So I will then study this in respect of everything that normally happens day to day, and how we normally create it to be functionally successful. So learning the safety 2 way is reviewing your policies to make sure they're not work as imagined, undertaking what's described as a work as done review. That's looking at how people actually work, watching them, asking them, talking to them, interviewing them through things like ethnography or something called video reflexivity, which is where you film a short periods of mundane tasks. You plot these on a flowchart and you look at the difference between the imagined policy and the way in which people do things every day, and you compare the differences and ask yourself, so what do we have here? What's in the gap? And then you review the policy and the procedure to close that gap. But you also review the designs of the area, the equipment, the tools, and the tubes, not the way the people work, the design of everything around them. And you factor in all of those things, such as tiredness, distraction, stress, overwork, to layer in your systems to try to make them more resilient and safer. So the best way of finding this out, as I've said, is to interview people, actually talk to people, listen to them, hear them, and understand what their lives are like. Do field observations. Sometimes exchanging people between departments might provide a fresh set of eyes, a set of fresh eyes even, and even using things like people like students as really important people who can tell you what's going on, or somebody who's new to your organization. But even just simply undertaking a tour of the workplace will ultimately find out things that you possibly haven't noticed if you look at them a very different way. You look at them through the lens of, I want to actually look at this to really detect how we normally do things. And that's the use of video reflexivity. So this is the work of Jessica Mesman, who's a professor in safety, and she looks at existing practices that are no less valuable just because they exist. So she looks and asks us to pay attention to the mundane, the implicit local routine. So think of something that you do every single day. Pay attention to it and film it. Now, there's 2 things about that. The first thing is that you might do it in a subtly different way from somebody else. And that mundane approach that you do might be subtly different from somebody else's mundane approach. And if you film it and you sit around as a group, you will find neat, nice little tools and tips about how other people do the same thing that you do. Very rarely do we study the things that we do all of the time and get an absolute joy of finding a subtle little tweak that we can do. This is very much come from the world of sports science and sports psychology and coaching, that you look at something that you do every day and you tweak it to do it a little bit better and a little bit better. And when you watch other people do it, you get tools and tips from how they do it. So I'll just take a quick sip. This means you start to pay attention to these little local routines, the habits that you do, the daily norms, and you start to pay attention to what has become to you invisible because you just do it by habit. It's the kind of thing like driving a car and using the gear stick and all of that kind of thing. It just becomes a habit. If you start to pay attention to it, you notice how you do it. And you forget the competencies that you have because you use them every day. You forget how brilliant you are. And actually, that's another absolute joyful thing of this. When you film something that's mundane, you watch it together, you can sit there with your eyes wide open and your mouth wide open going, wow, we are amazing, aren't we? That we do these things and we do it so brilliantly and it works the vast majority of time. So video reflexivity, simply filming somebody for a very short time on a technique, helps you look at things differently and enables informal discussions and take steps to look at safety differently. So it's filming, holding a reflexive meeting with your colleagues, discussing constructively about what you see, gives you renewed awareness and taps into a group wisdom. So this is the lovely work of Jessica Mesman. The other thing you can do is using huddles and debriefs to actually highlight a golden day. When things go right, talk about when things go right. A day when it felt like the safety, the quality, the productivity worked. You had team collaboration and encouraged everyone to grow. You strengthened your leadership and team management. And a day that should be assessed at team level on a day-to-day basis. Every day you're learning from a golden day, and you have many, many, many more golden days than you imagine. So do you learn from failure or success and success? Do you use methods and tools that are fit for complex systems? Probably not, because there are very few of them out there at the moment, and this is what we're trying to develop. Do you ask why it failed this time when most of the time it goes okay? Do you actually ask those questions when you do incident investigations or any reviews, any after action reviews and so on? Do you see staff as the problem rather than the solution? And do you actually start to ask yourself, what is it about the system? And do you attribute cause and effect too quickly? So what you need to do is help others start to slowly develop and look at your current systems, focusing on learning rather than counting and collecting stuff. Organizations need to employ people who really know how to analyze incidents. This is what other high-risk industries do. And you need to conduct thematic reviews and investigations of complex systems, not just isolated events. And use relational and restorative approaches. So that's being lovely and kind, all those things we talked about in that polarity map of kindness to build up the trust and confidence in the care provided and the caregivers. And bring together this wonderful world of safety 1 and safety 2, where safety 1 is defined as a state as few things as possible go wrong, which is obviously a great intent, but also we add safety is defined as a state where as much as possible goes right. So I'm now going to draw out, and we've got a short amount of time to look at some of these questions, but these are the kind of things you might want to think about over lunch. So question 1, in your work, you are adapting and adjusting your actions and decisions all of the time, even if you're not aware of it. So when you think about Jessica Mesman's work about looking at mundanity, you're adapting and adjusting all of the time. Think over lunch about the ways in which you've adapted your practice over the last few months that have made a beneficial difference to the care that you provide. Question 2, and I'm going to put these in the chat room so that you can have a look at them over lunch, and we'll talk about them when we come back. In thinking about the adaptations that you've been making, what are the emerging new possibilities you've seen or experienced over the last few months that you want to continue? Just a quick, before we break for the 45 minutes lunch, just for those that go, I thought there was a number 5, Suze. How people respond and act to failure matters. is number 5, but I think it's really important to take that when we start talking about restorative just culture. So we're going to visit this in part 4 after lunch. So 12:14 time check. I'm going to put these questions in the chat room, and over lunch I'd like you to have a little think about these 2 questions, and then we'll talk about them when we come back. So if that's all right with you, Dan, I will
absolutely
unshare.
Lovely. I will stop recording, and we'll see you back here in 45 minutes. Thank you.
Right, see you back at 1 o'clock, everybody.
Thank you.